this patient has a soft lens. She's only 36 years old. We're doing a refractive lens exchange procedure. We'll mark her toric axis in just a minute. You can see it there. You can see from contact lens where the vessel's here. So you can expect some red cell escape when you go through them. Probably not a lot. That's a 2.4 incision. And we're going to put a little lidocaine in. So you're going to feel a little sting for a few seconds here. Yeah, that's good. So this is the R.J. Mackool toric axis marker designed by my son. And you can see that I put the 90-degree mark there and the superior mark up at 12 o'clock, and it automatically marks where the ink is at the 5-degree axis. And these are very soft titanium foot plates, so you don't get corneal abrasions with these. So next we're going to put viscode in the chamber. Now this is actually a highly myopic eye and a young person, so we may have decreased scleral rigidity and a tendency towards chamber collapse when we remove instruments like the phaco or INA. Alright, so that's Provisc underneath it. Now let's open the central capsule and just begin the tear like so. And while we haven't had any significant extraocular motion, I'm going to stabilize the globe, wet the cornea please, with the spatula. And then we'll grab the right side of this capsule tear and then go counterclockwise. And what I'm really doing is envisioning and watching the distance between the tear and the sphincter pupillary margin, and keeping that more or less constant as I go around. That'll give me a pretty centered round capsulorhexis, and that's probably about 4.5 millimeters, which is about what I like, smallish ones. Okay, so next is hydrodissection with the flat 23 gauge cannula, and I'm going to lift up. Those of you watching in 3D can appreciate the elevation. And with a soft nucleus, you try to push it down and it won't go down because it's soft. Now if I inject more on this side without releasing it, the whole thing might prolapse. Do I want that? No. So I'm just depressing the margins here to let the fluid that I put back there kind of come back in the anterior chamber a little bit. And I'll do just a little bit of gentle hydrodissection there, and there you go. Okay, so now we'll do viscodissection for 180 degrees. A little sweep back and forth there. And now we're ready to really phacoaspirate. We will not need ultrasound for this lens. So we'll test infusion capacity, turn the sleeve to get it good on both sides. And the soft lens is a vacuum procedure, meaning if you can use high vacuum, you'll minimize, or in this case, won't need any ultrasound. So there's no reason to use the lower flow, lower vacuum sculpt mode, so we'll go to quadrant removal now. And we'll aspirate the lens. And now let's see if we can rotate it with a spatula. No, not surprising. But if, as we aspirate, we go a little bit in a circular motion, we'll encourage the lens to follow into the phaco tip. And now with the spatula, I'll just slide this remaining area of nucleus. So there we go. By moving the phaco tip as we aspirate the soft lens, we don't just take out a chunk here and there. So now INA, 90-degree tip. I'm rotating the sleeve till I get very good infusion. And there's not a lot of cortex left here. more like just some strands here and there. And now we'll remove epithelium from underneath the anterior capsule for a good 180 degrees or so. So there won't be capsulorhexis contracture. And now we're ready to inject the OVD into the posterior chamber. And as we do that, notice the bulge. Again, you watching in 3D can see that, indicative of low ocular rigidity. And so as I inject, I'm just going to gently rub the posterior capsule and get those lens fibers to move into the periphery. There we go. And because this is such a large eye, large chamber, I've got another syringe of the Provisc here, and just getting a deeper fill. And again, in watching in 3D, you can appreciate that. So now the 7 diopter T8 IOL is going to be injected into the capsular sac. So I'm pushing away from me and down, and there goes the leading haptic optic, and now I'll tuck the trailing haptic optic into the capsular sac. Now the leading haptic did not release yet, so I'm just going to grasp it and squeeze it like that, and that will typically cause it to release. It didn't yet, but I'll squeeze it again. There we go. So eyes with low ocular rigidity, when you remove OVD, you may not want to remove it from the anterior chamber. Of course, you want to remove it from the capsular sac with a toric IOL, because you don't want it to rotate. And again, this is a large eye, so you definitely don't want to leave OVD back there. So I'm just going to rotate the IOL into position here. And then I'll leave the OVD in the anterior chamber and irrigate that out with a syringe. So let's see now. We'll get that pretty close to that 5-degree axis. And wet the cornea again, please. Okay, so I'm looking at those marks. That looks right on. Yeah, good. We'll see. Let me have the syringe. So now there's still OVD in the anterior chamber, but not for long. So the next thing I'm going to do is just seal the primary and side port incisions with some stromal hydration. You can see the OVD swirling around there. And I like this side-to-side irrigation in the incision. That hydrates the floor as well as the sides of the incision. And the IOP's nice and firm now. Okay, so now a final check. And I think that the location is good, but we'll take the toric axis marker one more time and double check that. So we'll go right back to our 5-degree axis, and then we'll take a good look. Yeah, it looks to me like it's exactly right on. So now what we want to do is irrigate the OVD out of the angle. So we did a sequential OVD removal, but that's a good thing to do in eyes with low ocular rigidity. So there we have it, a soft lens refractive lens exchange in a highly myopic eye.